So we are ready for our tumor board. This is a 56 years old male. He presents with nausea, vomiting, and biochemical evidence of acute renal failure, anemia. His creatinine at the beginning it was 12 milligrams per deciliter, and the hemoglobin was 6. The serum protein erythrophoresis showed an acute myeloma spike lambda, 4.6 XCT, demonstrated numerous skeletal, non-metabolic active lucent lesions. And with all that information in mind, he underwent bone marrow aspirate and biopsy, which shows 70 to 80% monotypic lambda plasma cells. So this is the clinical context, and I'm going to leave Dr. Arvitar with the rest of the molecular pathology.
And as you can already see here, we have mutations in ATM, FGFR3, ERG, KDR, and MAP2K. But more importantly, I think they also have the KRAS and additional mutation. More important of all is this translocation, the 414 translocations. And there's another, we see this frequently actually. It's not, I don't know if it is clinically relevant. So these are actually the mutations that detected in this particular patient. This is based on the DNA, and this is based on the RNA. Now you can really look at the expression actually, and again, this is in the multiple myeloma fraction, not in the granulocytic fractions. So remember, we separate the multiple myelomas cells from the granulocytes, and this is what we detect in the multiple myeloma. But what's really very interesting, as you can really see here, if you look at the difference in the variant allele frequencies. So here, if you look at the level of the mutations, put this on the side, but if you look at the level of the mutation on the RNA, they are significantly higher, especially FGFR3, as compared to what you see above here as in the 5% versus here in the 19 and 22%. Now the SH2D5 mutation, this is a germline mutations. It's not really in the DNA panel, but so this is simply a germline mutation detected in all the cells. But always when you see FGFR or some of these genes are in the RNA expressed at high level, you always must ask why the RNA is at higher level than the DNA. And the explanation for that actually is actually in the translocation, which I will come back to it let me go back to here. This is, you can really look at, this is the patient. You can really see there is overexpression of the NSD2, as you can see it here. There is BCMA and 138, but the level fairly low here because what we get not necessarily what in the bone marrow. The bone marrow had very high percentage of sample of plasma cells, but here it is not really very high what we got, despite the enrichment. So when we look at the chromosomal abnormalities, we see all these chromosomal 1q plus and practically trisomies of 3, 5, 6, 7, and so on, and deletion of the 13, versus in the myeloid fraction, we don't see any of these abnormalities. And this is 414 translocation. And again here, the breakpoint is within the gene. So this is a late disruption of the genes. Now, this late disruption of the genes actually, as this is based on the paper in Blood, if it is late disruption, this is more aggressive disease, as you can really see it here. They have more aggressive behavior. But more importantly, let me see if I have the expression levels of the FGFR. Okay, here. So FGFR3 here, expression is relatively high. Now, in the 414 translocations, there is NSD2 genes adjacent to the FGFR3. In the old literature, actually, the 414, people thought that translocation lead to translocating the FGFR3 to the immunoglobulin. Then later on, that was adjusted and put into NSD2 genes. Now, we get cases. Some of these cases lead to overexpression because of this translocation. Remember, this translocation brings the genes into the promoter enhancers of the immunoglobulin. So it increases the expression of the NSD2, but significant number of the cases, you don't see overexpression of FGFR3. Except in small proportion of these cases, we see overexpression of the NSD2 as well as the FGFR3 genes. And frankly, what's the clinical relevance of that, we don't know. I couldn't really come up or see any study to that fact, which is very interesting, but you will have higher chance of activating and overexpressing the FGFR based on our observation when the breakpoint on the NSD2 is late or a late disruption within the gene, which means like it is closer to the FGFR3. So it is quite possible that the enhancer of the immunoglobulin affecting two genes because of proximity of the breakpoint, which is a factor. And maybe that's really the reason why these cases will do worse, because there's overexpression of both the FGFR3 as well as the NSD2, rather than, it is late disruption versus early disruption. But again, I mean, more data need to be really looked into and see what's happening in this particular case. And that's actually it for this particular case when I discuss.